Good afternoon, everyone, and thank you for joining CMQCC for Improving Healthcare Response to Obstetric Hemorrhage, version 3.0 Toolkit Introduction. I am Valerie Cape, and I am one of the co-leads of the task force. I'd like to welcome you to the meeting today. For webinar logistics, the attendees are automatically muted upon entry, and the chat function has been turned off for this session. If you have questions, please type them into the Q&A box, and they will be addressed if time allows. Both the slides and the recording of this session will be posted on the CMQCC website within 7 business days of the webinar. An evaluation survey link will be sent to all attendees within 24 hours and must be completed if an RN would like to request contact hours. Thank you in advance for your response. Throughout the toolkit in this presentation, specific terminology has been used, and we just note it here for your information that this is also included in the toolkit. The learning objectives are to know the impact of obstetric hemorrhage on morbidity and mortality, to describe the management guidelines for obstetric hemorrhage, to identify systems of support for women, families, and caregivers after an obstetric hemorrhage, to understand the importance of debriefs, case reviews, process measures, and outcome measures in obstetric quality improvement, and to learn implementation strategies for best practices. With that, I'd like to turn it over to Dr. Elliott Main, the CMQCC Medical Director. Elliott.
Thank you, Valerie. And if we could have the next slide. First, I'd like to introduce you to CMQCC. We were founded in 2006. And one of our first activities in concert with the California Department of Public Health was to staff the Maternal Mortality Review Committee for the state of California. And you could see on the right-hand side, after working on hemorrhage and hypertension for about a decade, there has been significant reduction in maternal mortality in California compared to the US in red. Our approach to quality improvement has been to translate the maternal mortality reviews into action, to take lessons from them, and then to scale them up into large-scale quality improvements, partner with everyone, and have a data-driven opportunity through the Maternal Data Center. Next slide. Today, I'd like to thank our task force chairs for their leadership, patience, and perseverance. That's Dr. David Lagrew, Dr. Jennifer McNulty, Christa Sakowski, and Valerie Cape. They had the challenge and the honor, next slide, of shepherding a very skilled group of task force members from all over the state of California, with a lot of experience in working with hemorrhage and working with quality improvement. This included patient representatives, nurses, physicians, anesthesiologists, and pharmacists. Next slide. The next couple of slides will give a little bit of background about obstetric hemorrhage in California and in the United States. As you can see here, the rates of hemorrhage, postpartum hemorrhage, PPH, with or without including blood transfusion, has been rising dramatically since about the year 1998 or 2000. This has continued in the years off this slide into 2020. Next slide. When you look at maternal mortality data, and this is our data in California, hemorrhage over this time period is the #2 cause of maternal mortality at about 15%. Very similar to sepsis and very similar nationwide with hypertensive diseases of pregnancy. Next slide. However, hemorrhage is not a single diagnosis. It's actually has a whole list of underlying conditions that can lead to hemorrhage and to lead to hemorrhage death. Uterine atony and placenta accreta percreta are the 2 most common etiologies. Uterine rupture and surgical complications are others. But again, these are causes of death as opposed to causes of hemorrhage. Keep these in mind. These remain significant issues, particularly placenta accreta in the most recent years. The other OB hemorrhage complications that result in death include amniotic fluid embolism, preeclampsia. It's interesting that preeclamptic moms have much higher rates of postpartum hemorrhage. Sepsis can also lead to hemorrhage as well as liver disorders. Next slide. When we've reviewed maternal deaths, there are themes that jumped out. In almost every case, there was multiple improvement opportunities here illustrated in this slide. Delayed response to clinical warning signs, ineffective care, i.e. not using the right medications or the right procedures, misdiagnosis, i.e. concealed hemorrhage, which we're going to talk about in depth, failure to consult, and lack of continuity of care. In these deaths, over 90% had at least one of these improvement opportunities at the provider level. So there was real opportunity for improvement. Next. We can't have a discussion about obstetric care today without talking about the disparities that are present for many racial and ethnic groups, but for particularly Black and Native American women have significantly higher rates of morbidity and higher case fatalities, even for obstetric hemorrhage. Black and Hispanic birthing persons have diagnosis of hemorrhage, who have a diagnosis of hemorrhage are approximately 4 times more likely to die than white women. So this is a call to arms. Next slide. We have data from our very first large-scale collaborative, 130 hospitals, that the implementation of a standardized safety bundle, such as the C-ONQS bundle, was associated with reduced rates of severe maternal morbidity, the major complications of delivery, for all races, and it actually even narrowed the outcome between Black and white women by over 60%. But it was only 60%. We did identify that Black women are increased risk for SMM for additional reasons. SMM is highly driven by transfusions, and anemia and cesarean both increase the transfusion risk. So these are areas that we've continued to work on and plan to work on in the future. Next slide. So I'd like to start off a discussion of our toolkit with Christa Sakowski, our clinical lead at C-ONQS. Thank you, Christa.
Thanks, Elliott. It's my pleasure to introduce you to the second revision of the Improving Healthcare Response to Obstetric Hemorrhage. Updates have been made to the previous toolkit with content such as parameters have been added for ongoing risk assessment at admission, the start of the second stage of labor, transfer to postpartum care, and as the patient's status changes during the birth hospitalization. It emphasizes the importance of assessment for concealed hemorrhage. There's strong support for quantitative blood loss, along with clarification of definitions. There have been changes in the recommendation for misoprostol and updated recommendations for the use of tranexamic acid as an adjunctive therapy. There's also been a further decrease in enthusiasm for factor VII. Additionally, equity issues are recognized throughout the toolkit. Next slide. New sections in this edition include implementing and sustaining maternal quality, safety, and performance improvement for maternal hemorrhage, using the electronic health record to improve the management of obstetric hemorrhage, management of iron deficiency anemia, secondary obstetric hemorrhage and readmission, and using outcome metrics for hemorrhage-related QI projects. Next slide. The revised toolkit is organized using the 4R principles of readiness, recognition, response, and reporting to align with the National Maternal Safety Bundles from the Alliance for Innovation in Maternal Health, or AIM. National efforts are underway to define a 5th R, respectful care, to be interwoven into the original 4 Rs, underscoring the importance of patient experience. The revised toolkit content has been aligned with the National Partnership for Maternal Safety Hemorrhage Bundle and the Joint Commission Standards for Maternal Safety. Next slide. So we're going to move through readiness. Next slide. Implementation is not a one-size-fits-all endeavor, and each facility will need to address unique challenges depending on local resources and organizational priorities. Bundle implementation, whether it occurs all at once or incrementally over time, is critical to achieve meaningful, sustainable, and systems-level improvements that will improve hospital-based perinatal outcomes. We encourage a rapid cycle plan, do, study, act approach to implementation. It is important to remember that quality improvement work should never be dependent on a single person, but rather operate as an integrated unit-level process that can be easily replicated to ensure ongoing success. Involving the entire team is integral. Next step. The Joint Commission Standards for Maternal Safety. Reporting and systems learning content highlighted in the Alliance for Innovation on Maternal Safety and the California Maternal Quality Care Collaborative hemorrhage and maternal safety bundles inform the Joint Commission in developing standards for maternal safety to reduce the likelihood of harm related to obstetric hemorrhage. The Joint Commission standards for maternal safety go beyond metric benchmarks and require leaders of hospitals, health systems, and birth facilities to examine the processes and procedures surrounding the care of women experiencing maternal hemorrhage and hypertension or preeclampsia with severe features. While the intention of these standards is to improve the quality and safety of perinatal care in Joint Commission accredited hospitals, standards such as these are useful for all birth facilities to review and adopt, regardless of the accreditation body, to ensure quality care for women and their newborns. These standards are recommended as a bundle to guide implementation of this toolkit. This approach will organize and focus implementation efforts. Next slide. Ongoing risk factor assessment. Obstetric hemorrhage is considered the most preventable cause of maternal death, with some estimates saying up to 70% of cases were preventable. Using an obstetric risk assessment tool can raise awareness about hemorrhage prevention and treatment. In its guidelines for standards for maternal safety, the Joint Commission mandates that hemorrhage risk assessment be performed for every pregnant patient on admission to labor and delivery, as well as admission to postpartum. Therefore, hemorrhage risk assessment is now a process measure. If a patient is identified as high risk for obstetric hemorrhage, experienced staff and key resources can be mobilized in advance of the delivery. Decisions about the timing, mode, and location for delivery may be influenced by each patient's risk. For example, patients at high risk for severe maternal hemorrhage, such as placenta accreta spectrum, may be advised to plan to give birth at a high level of care center that has in-house surgical and anesthesia staff, a well-stocked blood bank, and the necessary equipment and resources for managing severe obstetric hemorrhage. Performing risk assessments may allow the maternity team to better prepare for the majority of hemorrhages, although no risk assessment guide has been proven to capture every patient who experiences an obstetric hemorrhage. Up to 40% of patients who experience postpartum hemorrhage have no identifiable risk factors. Next slide. CMQCC's risk assessment version 3 has been updated to reflect the latest research. Several risk assessment tools have been promoted by maternal safety agencies, including CMQCC, A1, and the Safe Motherhood Initiative. Based on expert opinion, these tools classify patients as low, medium, and high risk for obstetric hemorrhage to guide resource preparedness. Ultimately, performing risk assessments serves to increase surveillance and vigilance so that response and treatment can be timely. While there will always be sudden severe hemorrhages that require activation of a massive transfusion protocol, foreknowledge of high hemorrhage risk status can allow resources to be readily available, whether it be blood products, hemorrhage carts, staff, or an open OR. This represents a proactive rather than reactive approach to hemorrhage response. Those risk factors shaded in gray have been added since Toolkit version 2. Next slide. The Joint Commission requires that an assessment using an evidence-based tool for determining maternal hemorrhage risk be completed on admission to labor and delivery and on transfer to postpartum. The risk assessment table has been updated to include delivery and ongoing postpartum risk factors. Postpartum providers should be trained in risk assessment and coordinated resource activation. The care team responsible for hemorrhage response should communicate medium and high risk status and risk factors with the patient and support team. Next slide. While the care plan will depend on the cause of the elevated hemorrhage risk, For example, planning interventions for placenta accreta spectrum is different than planning interventions for choreo. It is important to develop a standardized approach for communicating hemorrhage risk within the care team. What resources are we able to mobilize based on risk? The hemorrhage card can be placed outside of the room, consideration of hemorrhage risk in our staffing ratios, ensuring that all QBL equipment is available and present at delivery, preparations including communication that may be done in the following ways: adding alerts to the EHR banner to identify high-risk patients, clearly identifying patients' risk on the labor and delivery whiteboard, making the hemorrhage risk assessment a standard data element included in safety huddles and patient handoffs. And before birth, the care team should ensure that all providers are aware of the patient risk level. For patients considered high risk, individual staff should be assigned specific roles. We advise apprising team members of the potential for obstetric hemorrhage and planning appropriate mitigation strategies. Additional preparation includes blood bank orders per hospital protocol, room that is geographically close to the OR, and the areas are cleared of obstructions. Consider potential uses of the rapid infuser or cell saver technology as applicable, and increase patient surveillance, frequent rounding, vital sign and fundal checks, and bleeding assessments. It's also important to include the psychosocial well-being of patients and families. Identify patients who decline blood or blood products and review their advanced medical directive or refusal checklist. Patient preferences regarding transfusion should be communicated to the care team and actively incorporated into the care plan. Next. And with that, I'm going to turn it over to Dr. McNulty.
Thank you, Christa. Welcome, everybody. Happy to be with you today. So as you heard from Christa, up to 40% of women who experience an obstetric hemorrhage don't have identifiable risk factors. Nevertheless, there are some prenatal considerations that we want to make sure that we address in advance of the woman presenting or birthing person presenting for her delivery. The 4 key things that I have listed here include iron deficiency anemia, inherited coagulation disorders, birthing persons who decline blood products, and those who have placenta accreta spectrum. With respect to iron deficiency anemia, anemia is one of the most important and common, as well as modifiable contributor to severe maternal morbidity. And it's very important that we aggressively treat anemia that's due to iron deficiency and even consider the use of IV iron products in women for whom we have not successfully treated their deficiency with oral iron, or in whom we need rapid iron repletion, such as identification of this condition in the 3rd trimester. Inherited coagulation disorders are not common, but it is crucial to identify them and plan in advance for those. And these may be a contributor to delayed postpartum hemorrhage in the first 2 weeks after delivery. And then optimal management of individuals who decline blood products obviously includes aggressive treatment of iron deficiency anemia, as well as detailed management plans in advance of their delivery. Next, please. So one of the things that's so crucial to understand about iron deficiency anemia is that this is unfortunately much more prevalent and disproportionately affects women who are Black and Hispanic backgrounds. But in all individuals, it's quite common. One of the things that's important is engaging the patient in the goals of treatment. And if we do not speak to individuals about why it's so important to treat anemia, we will not be very successful in engaging people in that treatment. We need to talk to them about our goals of decreasing the risk of transfusion, even if they don't have experience a hemorrhage. And there is increasing amounts of data suggesting that adequate improvement of anemia actually can improve postpartum recovery of that individual. It's crucial to provide information on how to correctly take oral iron therapy. And this is something that when I was early in my training, we did not learn very much about. We would commonly hand out a prescription and say, you have anemia, please take this. And we would not discuss anything about how to take it. And that turns out to be really crucial. Oral ferrous iron compounds are the first-line treatment because they have good bioavailability and they are absorbed in the gut where they should be absorbed. Delayed absorption products, enteric-coated products are often prescribed. However, those are very poorly absorbed and tend to bypass the site of absorption in the gut. Intravenous IV iron should also be considered. Although there are calculations one can do to determine a dose, most of our patients have sufficient iron depletion that they in fact can just be treated with a single 1 gram dose. And again, considerations include, when do we think this individual is going to deliver? How close are we to that time of delivery? And did they have symptoms that were unmanageable with oral iron treatment that means we need to move to an IV route? Next, please. Inherited bleeding disorders in pregnancy, while not common, are something that are crucial to identify. It's really important in the initial OB intake to review the patient's family, surgical, and pregnancy history for any clinical symptoms of excessive bleeding. I always ask my patients about wisdom teeth or other dental work that may have led to unexpected abnormal bleeding. Many patients don't list dental work on their surgical history, but I always make a point to specifically ask about that. Also a history of menorrhagia, particularly for individuals who had that beginning from the time of menarche. Maternal fetal medicine, hematology, and anesthesia consults should be obtained in advance of delivery to coordinate care. A detailed discussion of the different coagulation disorders is beyond the scope of this talk, but I will mention that von Willebrand's factor is certainly one of the most common that is encountered. And it is important to determine prior to delivery the type of von Willebrand's that a patient has. They won't necessarily know that, and to determine what the right course of treatment is, because it may vary depending on the type of von Willebrand's. Next slide, please. For those who I identify as unwilling to accept blood products, it is very important to identify that obviously in advance of their delivery and to coordinate care. It's also important to understand that individuals who decline blood products may have various willingness to accept certain treatments, and that those may not be uniform among people. And so going beyond just asking about, do you accept blood or do you not accept blood, we really need to get into the details of what products they would or would not accept, and also ask questions around ancillary treatment, such as use of a cell saver. And many individuals who will decline all blood products are still willing to accept cell saver, as an example. Again, prenatal optimization of hemoglobin is absolutely crucial. And the task force recommends that our target is a hemoglobin of greater than 12 grams per deciliter at the time of delivery for those who are unwilling to accept blood products. Next slide, please. So placenta accreta spectrum, as we all know, continues to increase associated with the increase in cesarean delivery in this country. The risk is obviously highest in women with a prior cesarean section and with a current placenta previa in this pregnancy. However, it is important to maintain some suspicion for this. We have seen individuals who have had a placenta accreta without a prior cesarean section, particularly with a history of uterine artery embolization for treatment of fibroids or other circumstances. Ultrasound remains the preferred tool for diagnosis of placenta accreta spectrum, and as Christa recommended, we really want to make sure that we've identified the best site for delivery of that individual, and that may be at a level 3 or level 4 maternal center location. Next slide, please. Hemorrhage carts are an important part of readiness, and I think we've all become relatively familiar with these. This is just an example of 2 different types of carts. The one on the left is one that has a built-in refrigerator so that one can store the uterotonic drugs that do require refrigeration in that location. The one on the right is a less expensive but still effective cart. It's important to make sure that we have carts in all the locations where a hemorrhage could be encountered. And there are suggestions in the toolkit about what contents might include. Next slide, please. Simulation and drills remain an important part of our work. It is so important to practice these events. And we know from case reviews and from extensive research that one of the biggest challenges we have in a rare emergency is communication among team members. So when we do simulation and drills, we're not just rehearsing mechanical skills like putting in an IV or putting in an intrauterine balloon, but we're also really modeling our ability to communicate with one another to deliver effective care. In situ drills are simulations that occur in the patient care area and can be a very cost-effective way to maximize time and resources. It is not necessary to have a fancy model and fancy supplies in order to do simulation and drills. Both may have a place to play and can be important, but a low resolution drill is a very valuable way to practice our teamwork. Next, please. And I would be remiss in not speaking a little bit about reminding us all that reducing racial disparities must remain at the core of our mission in obstetric care. And so we know that implicit bias training can be one tool that we can use to help impact these disparities. We would not expect that bias training alone will lead to immediate improvements in these disparities, but certainly implicit bias training is important for all of us in improving patient-provider communication, highlighting behaviors that can be corrected, and beginning the work of providing more equitable care for pregnancy-capable people. And there are listed here 3 sites where implicit bias training that is specific to maternity care. I'm familiar with all of these. They are all very excellent, and all 3 of these meet the requirement in California that we all have undergone implicit bias training if we are a perinatal provider. Next slide. And I'm going to introduce Dr. David Lagrew to continue this journey.
Thanks, Dr. McNulty. Next slide. As was mentioned in the intro, one of the additions to this toolkit is a chapter on how to integrate the tools from your electronic health record into your hemorrhage management. So things like documentation templates, best practice advisories, alerts, standardized order sets, communication tools, and specific reports that let you follow your metrics. These can all be integrated as well as early warning systems, which can help trigger a more timely response. So these, along with care pathways and other things, the chapter reviews a lot of the different information on these tools. Next slide. The other point, and this was identified in a couple of our toolkits, is the case use for low resource hospitals. Clearly, as you're implementing the toolkits, there are special considerations that you have to have. So clearly better screening, better communication, staff's understanding response times and what your blood product availability is. And I think most of us recommend when you're in this type of situation, it's really about getting your teams mobilized early and a very conscious effort to focus on that. Next slide. Let's look at some of the recognition tools in our toolkit. Next slide. Remember that the ACOG defines excessive hemorrhage as greater than 1,000 for either a vaginal or cesarean birth, but they say that it's abnormal to have greater than 500. And this is why in our toolkit and our algorithms, we recommend that in a vaginal delivery, anything greater than 500 requires some response if there's continued bleeding. Next slide. This toolkit also validates that active management of labor is important, but the key aspect of that is really the administration of oxytocin. So we once again are recommending that be used, but the real focus should be given on oxytocin. We also, in looking at the literature and expert recommendations, validated that delayed cord clamping does not seem to increase the risk for hemorrhage, and therefore this technique, which of course is used to improve neonatal outcomes, is reasonable in the vast majority of cases. And finally, of course, we recommend that standardized oxytocin for prophylaxis be in every unit. Next slide. Now, the algorithm to manage was tweaked in Toolkit 3.0. We did add in prenatal and postnatal to try to get that idea of the continuum, particularly with things like treating anemia and things of that nature ahead of time. And of course, careful follow-up of high-risk individuals in the postpartum period. The stages of response basically are unchanged. However, we did try to emphasize, as Dr. Main pointed out, when you really look at poor outcomes, a lot of times it's unfortunately because of concealed hemorrhage. So we tried to tweak the algorithm to put that into the mindset of providers as they go through the progressions in various stages. Last comment on this is, just as we have in previous toolkits, the stages are based upon cumulative blood loss. In other words, we again reaffirmed that because physiologic changes don't occur until 40% of the blood loss occurs, that you need triggers that aren't based upon solely on vital signs and or obviously laboratory values. Next slide. Along that nature, we also wanted to make better definitions and clarify some of the nomenclature around blood loss. Obviously, traditional estimated blood loss, or EBL, has been time honored. But as many organizations, including our own, have said, a better careful technique of quantitative blood loss is indicated. And what we tried to do in the toolkit is also talk about the different methodologies such as gravimetric, volumetric, and the new technique with equipment of colorimetric, so that we could define how those are given. And lastly, underline the importance of the term cumulative blood loss. As you respond to obstetrical hemorrhage, it is not, it is the cumulative blood loss that is important. In other words, the antepartum events, the delivery, the recovery, the postpartum individual QBL measurements should be added together to form cumulative blood loss. Next slide. Now, the rationale for QBL has been widely published before, and we just reiterated those things, that if you don't do it routinely, the staff doesn't learn the technique. It adds in the uncertainty of should we do it, should we not do it. It also, from observations, the fact that while people were pretty good about blood loss estimation in the operating room or perhaps at the delivery, that when you got into the antepartum, postpartum period, there was just less focus on that. And therefore, again, doing everything by QBL is what we are recommending. Next slide. And as I mentioned, cumulative blood loss drives most of our management algorithms. But again, because of the concern over concealed hemorrhage, you cannot ignore vital signs. You cannot ignore things like urine output, confusion on part of the patient or the family concerns, et cetera, to really pick up concealed hemorrhage where it's not obvious where the blood's going. You really need to have a high index of suspicion. And again, we underlined that. Next slide. Now, as far as where should you look and things of that nature, obviously a comprehensive approach on vaginal exams, placenta, the uterus, the abdomen, lab parameters like coagulopathy. There are several different areas that one has to keep in mind, and there's some subtleties to these. So, for example, when we see blood from the vagina, we need to, in the back of our minds, think about cervical or vaginal laceration. So doing speculum exams with good lighting and things of that nature, clearly important. When we examine the uterus, we can't just go by the fundal aspect. We really need to think about what's inside, perhaps looking by ultrasound or other methods, or doing a bimanual where we make sure we are assessing the lower uterine segment for things like lower uterine segment apnea or clots, things of that nature. And other modalities such as ultrasound and CT scan should be added to our armamentarium. Next slide. As I mentioned, whenever triggers are going off, vital signs, and they don't equal the cumulative blood loss, one really needs to think about concealed hemorrhage. And as has been mentioned, this is an area we really want to focus where I think if our QI processes reinforce this, several of these cases can get picked up. Next slide. Concealed hemorrhage should really be considered strongly if the patient's had a prior C-section, she's post-op from a C-section, she complains of abdominal pain, think abdominal wall hematoma, a cervical vaginal laceration. Does she have some rectal pain? In other words, is there any retroperitoneal bleeding that's getting down to the area where it's causing things like that? And particularly with unexplained confusion or infection such as chorioamnionitis. These are the areas where you really have to be vigilant. Next slide. So with that, I'll turn it back to Dr. McNulty to talk about some of the response issues.
Thank you, David. So I'm going to touch on several things you saw on that slide. Let's speak first about rapid response teams. So one of the things that the Joint Commission tells us is that we need to understand as a unit who is on our team. And one of the things that's a little bit important to think about when you think about hemorrhage is that the folks who have the expertise to care for a woman who's experiencing a hemorrhage are likely going to be different people than on your hospital-wide rapid response team. There is evidence suggesting that an OB-specific rapid response team can have a positive impact on patient safety. It is important to have predetermined minimum calling criteria, which would tell us when to activate the rapid response team. And it is also recommended there be a predetermined process to notify all team members simultaneously whenever possible. For many hospitals, that will be an overhead call, but again, it may be different depending on which hospital that you're at. The OB rapid response members should have a working understanding of what their specific roles are during an OB hemorrhage. Common team members would include anesthesiology, would include nurses, including folks who can do quantification of blood loss, as well as scribing. Drills and simulations in your setting should include whatever the processes have been determined for activating that OB rapid response team. Next slide. I'm going to speak a little bit on medications for both prevention and treatment of postpartum hemorrhage. Oxytocin does remain the medication of choice for both prevention as well as treatment of postpartum hemorrhage. Second-line agents, when needed for uterine apnea that is unresponsive to oxytocin, would include methogen or hemabate. One of the things that I want to highlight in this version of the toolkit is that misoprostol is no longer considered a preferred second-line uterotonic agent and really should be reserved to use in patients with asthma and hypertension simultaneously, in which the other two drugs cannot be utilized. Tranexamic acid has been shown to reduce mortality due to postpartum hemorrhage. Certainly, if given within 3 hours of the recognition of the hemorrhage, we would advocate it be given earlier than that in a hemorrhage situation. Keep in mind that the TXA does not, by itself is not a uterotonic agent, so it's an adjunct in the setting of uteronatony. Also important to keep in mind is that when there have been inadequate or lack of response to uterotonic agents in the setting of atony, clinicians need to move promptly to next steps, such as surgical methods of treatment, and not to continue sort of in the same groove and the same rut of using drugs. The other thing that I would add that it's important is to consider that have we definitely ruled out other causes of hemorrhage. I've seen too many cases where there's phone management of uteronatony, use of orders for medications over the phone without the proper clinical examination to determine if we have indeed have atony or have we missed a laceration or some other cause. Next slide. So one of the tricky things with oxytocin is we don't really have a clear, this is the best rate, this is the best bolus, but studies do suggest that a combination of a more rapid infusion of dilute oxytocin combined with an ongoing infusion is probably a good combination. The toolkit has a number of different options and possible protocols for the use of oxytocin prophylaxis, as well as for treatment. Again, I think there have been a number of studies looking at this, and I think probably more study is needed to tell us exactly what the right combination is. Nevertheless, there are many recommendations that we standardize oxytocin prophylaxis, that we use standardized pre-mixed bags, that we do not add oxytocin to bags with a lot of variation. And several organizations have recommended that we infuse oxytocin with standardized pump settings. Next slide, please. Indications for blood transfusion certainly include evidence of hemodynamic compromise, a high rate and rapid magnitude of blood loss without waiting for laboratory data, certainly in that setting, may depend on the etiology of the bleeding and how likely the clinician is thinking that we may be able to get this bleeding controlled, what the response to the medical surgical management thus far has been, and certainly augmented by laboratory and point of care data when available. But the key message here is do not wait for laboratory results to begin transfusion when you have some of these components above. Next slide. The Joint Commission is very clear that all hospitals that deliver babies and provide obstetric delivery care should have a protocol in place for the emergency release of blood and a protocol for massive transfusion. The emergency release of packed blood cells is one component of that, and those should be available to us and maybe uncross-match if necessary. If the patient has already been typed in cross-match, obviously we can use cross-match blood, but we need to be able to access blood promptly, even if it's not cross-matched in an obstetric hemorrhage situation. And then the Joint Commission also refers to having a massive transfusion protocol in place, which we should consider activating if there's continued ongoing excessive blood loss. Common protocols include 4 to 6 units of type O packed red blood cells, 4 units of plasma and 1 unit of platelets, but we don't have a definitive answer as to what the right ratio is, but the notion is that we can provide large volumes of blood when the time required to prepare and transport those blood products must be short. Once bleeding has been controlled, we can deactivate a massive transfusion protocol and transition to cross-match compatible blood products and can integrate laboratory data as it becomes available to us. Next slide. The concept of disseminated intravascular coagulopathy, just a couple of notes on that. In most situations in obstetrics, we're actually not talking about DIC to describe coagulopathy, we're really talking about coagulopathy as a result of dilution. However, DIC does occur in some specific obstetric conditions, such as amniotic fluid embolus, severe placental abruption, and sepsis with associated hemorrhage. It is likely that most women who experience postpartum hemorrhage are developing coagulopathy, as I mentioned, because of dilution. But the terms sometimes are used interchangeably. Next slide. A note on uterine balloon tamponade. There are certainly many years of data on the use of this such a device, and it is a recommended modality when uterine atony-related hemorrhage is occurring and our uterotonic tonic therapy supplemented by tranexamic acid are ineffective or perhaps were not available. It is important to think about, if you're placing a balloon, what your next step is, because balloons are not always successful. And so we need to think about, have we notified an operating room? Maybe we need to place this in the operating room. Do we have the preparations available for possible hysterectomy if our balloon does not work? Do we have the right personnel on site? Do we need blood available at the bedside? Success rates have ranged quite widely depending on the series that you look at. It is the feeling of the task force members, and based on our clinical experience as well as what has been reported, that using ultrasound guidance for placement and post-placement monitoring may be very useful and should be considered. We are always worried about concealed hemorrhage, and is there bleeding going on in the uterus that we are not seeing because of the placement of the balloon. So it is important to continue to monitor these patients and to have a backup plan. Next slide. Again, just to drive that point home, we definitely recommend considering mobilization of additional personnel and really thinking about what our next plan is going to be should the balloon be unsuccessful. Next slide. Other modalities that have been used include compression sutures. These include the originally described B. Lynch suturing technique, as well as Heyman sutures, as well as Cho square sutures. Available evidence doesn't tell us which method is clearly better than another. And the protocols for the timing and method of placement of sutures and balloons should be added to institutional policies and procedures. Because these don't get utilized a lot, diagrams with the technique may be helpful, placed on a large laminated size and the hemorrhage cart. Different hospitals may choose to do different things as cues. And these are certainly techniques that can be practiced during skill labs on uterine models. We did that once in the Hemorrhage Collaborative in California. Next slide. Indications, complications, and effectiveness of vaso-occlusive balloons and embolization techniques are not well established and really need to be approached with caution. UAE may be available in some hospitals, but does require a patient to be reasonably stable. And the task force feels it's crucial that a physician who is immediately able to switch to plan B and again move to a laparotomy should be available and in-house. Next slide. Christa, I'm going to hand it off to you.
Thanks, Jennifer. Next slide. So some key points to consider when communicating with patients after obstetric hemorrhage is that the patients actually really need to understand the events that happen to them and have the availability of discussion with providers. So formal discussions about patient experience and prognosis should occur throughout the hospitalization and during subsequent postpartum visits. There is a significant and clinically relevant increased risk for women to develop post-traumatic stress disorder after experiencing a severe postpartum hemorrhage. We need to ensure that patients who experience hemorrhage receive a detailed discharge summary in writing. It's really hard to absorb all of the technical information that we share with them. And an example of a discharge summary is included within the toolkit. Prior to discharge, patients who experience hemorrhage should receive a contact information of a resource person who can answer questions about their care or ongoing concerns. And this can look different depending on your facility and the way that care is provided. Next slide. Providers caring for patients with prenatally suspected or diagnosed PAS should counsel patients extensively about potential risks and complications as early as possible in pregnancy. Patients with accreta are at increased risk for hemorrhage, blood transfusion, bladder and urethral damage, infection, the need for intubation, prolonged hospitalization, ICU admission, the need for reoperation, and thromboembolic events and death. Discussion should involve the relative likelihood for hysterectomy and subsequent infertility. It is also important for providers to be aware of mental health support needs for their patients with PAS. Next slide. There has been relatively little investigation of the incidence and risk of secondary hemorrhage or severe bleeding that occurs between 24 hours and 42 days after birth and occurs in 1% of pregnancies. The overall risk for postpartum readmission is increasing from 1.72% in 2004 to 2.16% in 2011, and hemorrhage or retained products of conception are the primary or associated diagnoses in 13% of all postpartum readmissions. A study using population data on births occurring between 2010 and 2014 was the first to focus on how postpartum hemorrhage is associated with hospital readmission and found that 82% of readmissions occurred less than 20 days after discharge. These patients often present to the emergency department after discharge, and ED personnel should be familiar with the risk factors and signs and symptoms of postpartum hemorrhage, including evaluation of postpartum bleeding and the assessment of clots. It is important for the ED to identify whether patients that present have been pregnant within the last 6 weeks. And there is an example of an infographic that you can hang within your ED in order for patients to self-identify. It is important when we're developing all these kinds of protocols, rolling out education for hemorrhage and what the processes are going to look like in obstetrics, that we closely integrate the ED department and consider including them in even skills days when it comes to QBL measurement, for example, so that they're not left out of the loop. Next slide. And then I'm going to hand it over to David for the last part.
Great. Let's take a look at some of the reporting. First off, obviously, is continuation and recommendations for debriefs and case reviews. These can really help you problem solve, look for systems issues, come up with a structured evaluation so that you can pick up things so that in the next cases and or in your simulations, you can really target the things that your institution needs. So we strongly recommend these as a typical part of what is done. Next slide. As far as outcome measures go, probably the big three are the severe maternal morbidity in hemorrhage cases, and tracking the number of massive transfusion cases, i.e. the number of times that you have to give 4 or more blood products in a delivery. These can be tracked and of course be done and really help define how your efforts are working. Next slide. As far as process measures go, what percentage of the time do we do risk assessment or QBL? What percentage of our cases did we do debriefs? And of course, what is the rate of our obstetrical hemorrhage staff education to physicians and nurses? These types of metrics can really help you track how you're doing, as well as improve your performance in these tasks. Next slide. For those of you who are lucky enough to participate in the California Maternal Data Center, remember that there is a new patient safety watch section with hemorrhage patient safety, and many of the metrics I've just described are there and readily available. Of note, there are a couple that do require supplemental files and entry, such as anemia on admission, and as well QBL cumulative values, which again can be extracted. Now, many of these, hopefully going forward, will be able to be pulled directly out of the EMR and therefore be more readily available. Next slide. So with that, I'm going to turn it back to Valerie.
Thank you. Thank you, Dr. McNulty and Dr. Lagrew and Christa for the great presentations, and Dr. Main. We really appreciate everyone that has joined us today. If you have more questions, you can send them to us at info@cmqcc.org, and we will try to reach out to you. And the toolkit can also be found on the CMQCC website. And again, for those who are still with us, the slides and the webinar recording will be available on the CMQCC website 7 days after this presentation. Thank you again so much for joining us, and we'll sign off for today. Have a great afternoon.